A concept we hear a lot about in orthopedics is clearing or screening the spine. And the problem with that lies in the definition. What does it mean to screen or clear the spine? What we all agree to is that it means checking to see if extremity signs and symptoms are coming from a problem in the spine. But how clinicians do clearing of the spine or screening of the spine is a different story. If I'm not mistaken, what I learned in my DPT program was to move the low back or move the neck in a few directions and assess if it changes or increases or produces the extremity symptoms at that time. So it could look like bending and touching your toes for low back flexion, extending the back, and maybe rotating or side bending or side gliding, and seeing if in those simple movements knee pain was produced or increased, the pain, of course, that the patient is complaining about. I think this type of screening falls way short of what we need to do when it comes to addressing where extremity complaints are coming from. The XBOS study alludes to that recently, a study from a few years ago that shows a large percentage of patients with extremity symptoms, these symptoms can be reversed by moving the spine in a specific direction. For those types of patients, we would call it a mechanical problem in the low back, thoracic spine, or neck that can be fixed by moving in a specific direction. There are non-mechanical disorders in the spine, of course, that can cause extremity symptoms. Most obviously, people think of severe sciatica when a nerve is pinched in the low back, for example, and creating raging nerve pain down to the toes. Sometimes that's absolutely reversible with movements, and therefore I would call it a mechanical problem of the disc, but sometimes it's not. So structural problems too can create extremity symptoms from the spine. Talking about the extremity, however, we're not just referring to the entire extremity, we're referring to the joints and the spaces in between. So in the upper extremity, we could be talking about shoulder, elbow, or wrist problems, but we can also talk about arm, forearm, and hand symptoms. In the lower extremity, it's the hip, the thigh, the knee, the leg, the ankle, the foot, and the toes. So what I use now to look for or to investigate if someone's extremity symptoms and signs are coming from a problem in the spine is Robin McKenzie's repeated movement testing. And there are 4 textbooks that go over how to do repeated movement testing of the lumbar spine, of the cervical spine, of the thoracic spine to assess if a problem in the spine, most notably or most usually a mechanical problem that can be fixed with movement, if there's a problem in the spine that's causing the extremity signs and symptoms. Now, I don't always look at the spine for an extremity sign or symptom or complaint. Most times I am because the prevalence is so high. But if a patient's verbal history, if a patient's baselines, if they all corroborate that it's more likely that the extremity symptom is coming from the extremity, from the location itself, or maybe another part in the extremity, maybe proximally, I will go there first. My goal when it comes to part 3 of my evaluation in the testing part is to do the testing that's most fruitful based on the information I've already gathered. So if everything about that patient's story is telling me that this knee pain is coming from the knee, I'm going to start my testing evaluation or testing investigation there. If there's ambivalence, if there's more likelihood that it's coming from the low back or maybe even the thoracic spine in rare cases, I will start the testing there. So screening the spine for me is a process that's very algorithmic, very involved. It doesn't just mean looking in a few directions and seeing if it recreates the patient's complaint. If I did that only, I would miss a slew of patients because you're not always going to produce a patient's symptom in the extremity by simple one-off movements. A lot of the times you need a different load, or you need more repetition, or you need more force. For example, I had a patient recently with normal pain-free movements of the lumbar spine, not normal in terms of movement loss, but normal in terms of no pain. There was moderate loss of flexion, moderate loss of extension, and minimal loss of left side glide and right side glide. The patient was presenting to me, however, with bilateral Achilles pain and right hip pain. Her history includes lumbar mechanical problems in the past, as well as lumbar surgery, and her history did not speak to bilateral Achilles tendinopathies or tendinitis or Achilles tears, for example. It did not speak to a hip problem that seemed mechanical or structural in nature. So even though moving the spine in those 4 directions did not reproduce symptoms in the extremities, I decided to start my testing with repeated movement testing of the lumbar spine. And so far, we're seeing improvements. I reckon that we need to restore her full extension, which will therefore also restore her side glides and flexion, or at least improve it considerably, in order to get the mechanical properties of the lumbar spine working better to alleviate symptoms in the hip and the bilateral Achilles tendons. That's my guess based on 1 or 2 visits that we've had so far, but we'll see where it goes. My point, however, is that I'm not necessarily excluding the spine if simple movements are not recreating the extremity complaints with those simple movements. I need to test further, especially if the verbal history and the baseline taking more likely incriminate the spine. Again, the XBOS study does a good job of showing how many extremity joint complaints and how many extremity kind of limb complaints are resolved by moving the spine in a specific direction. So I think different clinicians have different understandings, unfortunately, of what it means to screen the spine or clear the spine, meaning clear it from blame for extremity symptoms. I'm sure there are different methods that I haven't learned that other clinicians are using, but I think the methodology that I used in school is woefully short for actually finding the amount of patients whose spines aren't moving very well, and therefore they're having mechanical problems or symptoms in the extremities. Yes, people do lose motion in their extremity joints, like their shoulders or their knees, but if you took 100 people off the street, there'd be much more loss of range of motion in the spine. And I think that's contributing to, over time, this presentation of not only spine signs and symptoms, but also extremity signs and symptoms.